Spectacle lenses, atropine, light exposure. When it comes to managing myopia, there's no shortage of options, but not all of them hold up to scrutiny. Hi, I'm Dr. Ken Nischal, and I'm here to unpack the key takeaways from the 2025 WSPOS Myopia Consensus Statement. What works, what doesn't, and how to cut through the noise with evidence-based strategies that actually manage myopia progression. Let's get into the facts. You know, myopia has become a hot topic. You know, places like Singapore, China, Taiwan, they've been battling the myopia epidemic for years. And now, as it spreads globally across the world, there's so much confusion. People don't know what works. People don't have the time to go through all the data that's been published at a tremendous rate. So what the consensus statement does, the WSPOS 2025 statement, what it does, it encapsulates all the evidence in something that's easy to read and something that the practitioners and patients, parents, can look at and try and make sense of what might work for their child or for themselves. People used to say that if you undercorrect your myopic correction, then it retards the growth. Well, we know that that's not true. That does not work. They used to say that if you gave somebody bifocals, that would help. Well, we know that doesn't work. Then people said just plain contact lenses, you know, myopia correction contact lenses, they have an effect. We know that doesn't work. So the first thing is to help explain to practitioners what doesn't work and why it doesn't work. There is so much information about optical lenses, about pharmacological therapies, about behavioral interventions, that people are not sure what to believe. And what the consensus statement does, we look at data that is at least 2 years follow-up. Once we show people what doesn't work and why it doesn't work, and then give them data for what does, it's a game changer. No matter what you do, if a child is reading for close, that's a near task, then they are going to drive myopia. A couple of huge studies that show if you go outside and there's 2 hours daylight exposure every day, it's protective against myopia. Now, initially, people said it's protective if you don't have myopia, but even in children who have myopia, it's protective. Reading in dim light. There are some very good, excellent animal studies that show that when you rear a non-human primate, like a macaque monkey, in dim light, their ability to control emetropization, which is the control process of the eye trying to grow normally, is made dysfunctional. So now if you have a trigger that causes the eye to grow, near task, and they're doing it in dim light, their eyes get more and more myopic. So it's very simple. 2 hours daylight exposure outside, and you can wear sunglasses, it doesn't matter. You can wear a baseball cap, it doesn't matter. It's the lux is still higher. If you're reading for close, after 30 minutes, take a 5-minute break. And the last thing, do not let your children read in dim light. And in myopia, those behavioral interventions have a really strong effect. I think optical treatments are very important. The retinal defocus lenses work on the premise. While your central vision has good acuity, you don't want your peripheral retina to be in hyperopic defocus. So what they do is they focus light in the periphery of the retina so that it falls in front of the retina. That's called myopic defocus. So then what happens is the eyeball tries to stop growing. There is a contact lens technology which does the same thing. If I have a child who's 12 and plays soccer all the time, they're not going to want to wear glasses. And then you've got the dot technology. The dot technology is really interesting. If you have a high contrast on your retina, it drives myopia. So what they do is, if you like, they reduce the spatial contrast and have an effect in reducing axial length. I think orthokeratology is it's a very good option. So you've got to choose the right type of person, right personality to do orthokeratology. At this moment in time, many places in the world use compounding pharmacies to make low-dose atropine. And so, in many ways, it's the cheaper option. I mean, if a 7-year-old starts low-dose atropine, it's a daily drop for at least 7 years. When you take into account the cost of that, it may not be that different from using optical designs. What I think is going to happen is that we're going to have groups of children who do not want drops put in their eyes every day. I mean, you know, children don't like drops. And so that maybe they'll get the optical therapy. There is a very good study showing that low-level red light therapy is effective. There is some concern in certain parts of the world where it is approved that you could get retinal damage. So I think we need a bit more clarity about the risk to the retina to give people confidence. I think there is evidence that it's safe, and I think that with time, when we get more data, safety data, it'll become more popular. The consensus statement, the way it's built, the way it's set up, it's for parents, importantly practitioners, to go, I think I understand the gist of this. I've got a gestalt of what I can do. Now it's up to me whether I want to delve deeper.